Hi, everybody, and welcome back for our fourth in our weekly September is Gynecologic Cancer Awareness Month webinar series. So far, we've had a lot of fun, and this has gotten to be the highlight of the week for me. So I'm certainly glad that everybody is joining us this week, and I'm very glad that we have three guests joining us for our session tonight, which we have labeled Mind Matters, sort of the counterpart to all the physical discussion that we have throughout this month about physical symptoms of cancer and its treatments, and focusing more on the mind issues that arise with a cancer diagnosis. And we are very lucky to have three guests with us this evening. And so we're going to start by having each of them introduce themselves, and then we'll introduce different mind matters that we're going to talk about. And with the introductions of each of our guests, I think you'll get a sense of, when we talk about mind matters, the different aspects that we're thinking of this evening. So why don't we start, and I'm only picking based on who's in my upper left corner so I can go clockwise around and not get myself lost. Why don't we start with Dr. Vannorsdall?
Hi. Thank you for having me. So I'm a clinical neuropsychologist. My area of focus is on cognitive functioning in cancer patients and survivors. And most folks don't know what a neuropsychologist is, so I'll tell you a bit about sort of what I do. I meet with patients who are noticing difficulties with their thinking skills, and talk with them about what they've been noticing, how it's affecting their life, what other medical issues are going on, their background in terms of their schooling and family and psychiatric issues and things like that. I mean, try to get a good sense of sort of how their thinking skills are changing and affecting their quality of life. They go through some paper and pencil tests that check out those skills and give me a better sense of what their strengths and weaknesses are. And then we work together to craft a set of recommendations that help us address all of the different factors that we can address that contribute to cognitive functioning. So those are things like sleep, diet, exercise, mood, using cognitive strengths to compensate for areas of weakness, and sometimes even getting a little extra help in the workplace to help set up people for success as they're going through their treatment and recovery.
Reverend Cooper, do you want to go next?
Sure. So I'm Rhonda Cooper, and I'm the Cancer Center chaplain here at Hopkins. My background is as United Methodist pastor, and here at Hopkins, I'm like the general all-purpose chaplain. My training for hospital work was along the line of being a generalist in terms of religion and learning to connect with people across the spectrum of belief and unbelief for that matter. So I see patients in the inpatient setting, the outpatient setting, more lately by telephone contacts and some Zoom meetings and that type thing. I think that I have the best job in the Cancer Center, actually. Some of you may argue with me on that, but I love it. I love meeting people and working with the staff here. So that's a little bit about me, and if you have other questions, I'll be glad to answer.
That sounds great. And Sherri Cohen, last but not least.
Thank you. Good evening, everybody. My name is Sherri Cohen. I'm a licensed clinical professional counselor, and I have a private practice located in Towson, Maryland. I've had my own practice that has had a nice little niche working with either cancer patients or those who are helping taking care of a loved one who has cancer. Because not only does cancer treatment take its toll on the body, it also takes its toll on the mind and the spirit at times. Cancer patients express not feeling like themselves due to distress in different areas of their lives when they go through a cancer treatment. And what I love to do is to educate individuals to better understand and overcome those uncomfortable mental health effects that are associated with experiencing a traumatic event, which I kind of operationally define getting a cancer diagnosis, characterized by it's not something you can plan or anticipate, and it's characterized by experiencing at some point some sense of loss of control over the situation. And so it's very important for me to be able to experience the journey with individuals who are experiencing cancer and helping them understand how to get that balance back from a mental health perspective after they've gone through an experience where, oh my goodness, what is happening? And they have a whirlwind. I know that Mind Matters is so important, but I think I'll share with you a little tidbit. Life is filled with stressors, and one of the most important things that I love to empower people with is do something you love. I'll just let you in on a little secret. I have a personal passion for singing, and I zip myself out to Carroll County where nobody knows me, and I sing my little head off. Been doing it for years.
That is a great way to get us started and introduce us to some of the Mind Matters that we're going to talk about tonight. If each of you in that light do something you love, address one of those Mind Matters that comes up, a way to deal with the stress and tension of a new cancer diagnosis. When you're first meeting patients and talking to them sort of about Mind Matters, what's the first one that you try to focus on or elicit or ask questions about? As doctors, we sort of have a history that we take and we go very formulaically through things. So when you meet with patients or clients, depending on the language that each of you use, when you meet with folks, what is the first thing in your Mind Matter list that you go through, and how do you frame that Mind Matter for patients? Anybody can jump in.
I'll start because my training was such that I'm pretty open-ended with people when I first meet them. Like I try not to say, how are you? Because people go, well, how do you think I am? I'm in the hospital and I have cancer. But I'm open-ended to the point where I try to get a read on what's uppermost on their heart. We would call it, I would call it heart matters instead of mind matters. And when it's framed as what's on your heart or what's in your spirit, almost always the first thing that comes up is concern or worry about their family. Mm-hmm. It's so interesting, and maybe you all get this, but like whether it's a spouse or children, no matter how old they are, it's interesting. That's a real common thing. Like who's going to take care of them? If I don't get better, or how they're going to manage, and so that's really a big thing on their hearts and impacts their spirits, right? Because worry always does. So I would have to say that love and concern for family and friends or significant others is a real thing when I speak with patients.
I would love to share some feedback. Every time a new cancer patient comes in and starts to share with me their story, they're all sharing a story that is pretty much characteristic of, I'm feeling like I'm just not myself. They either come in strong or they don't come in strong. They come in with who they are as a diagnosis. And usually by the time they come to me and they're seeking some mental health counseling, they are sharing with me straight out of the gate. Their message is, I don't feel like myself. So for me, from a Mind Matters perspective, what's most important to me is to help normalize their reaction to the cancer diagnosis. Sometimes a little bit of time is in between their diagnosis and when I see them, but time usually is not so much of a factor in terms of how their response is to the diagnosis and a pattern of worry thinking, as you brought up before, a pattern of worry thinking that occurs. So I usually try to share with them at the very, very beginning, all of them, that their process makes sense. And I know they don't feel like themselves because they feel a sense of loss of control, but we're here to develop and help you reclaim that. And I think they get a lot of relief in that first session.
Great. And I know for me, when I'm meeting with folks, they're usually concerned about their thinking skills. They've come to me for that specific reason. And one of the things that I always try to sort of instill early on in our visits is the notion of optimism. A lot of what I'm doing is, hunting and sifting through data, the data I get from them from the interview, the data I get from their testing, but it's also a lot of education about the range of factors that can affect thinking and quality of life, and helping instill some hope that the notion of chemo brain, people are often concerned, well, this is my disease, this is my treatment, and what can I do to help myself feel better? I have to have this treatment. And I think a lot of what we do early on is really discuss how what I'm focused on is looking for all of the different ways that we can improve thinking skills, the avenues that are available to us. And that when we layer on several of those, patients really can have a pretty significant improvement in their quality of life, their ability to think more clearly and to feel more comfortable with the changes that they're going through.
What can you just tell us and start us off with what is chemo brain or what isn't chemo brain and what terms should we use instead?
Sure. So the notion of chemo brain is sort of the pop culture notion that patients who are receiving chemotherapy for treatment of their cancer often report that they are foggy. They can't multitask like they used to. Things are falling through the cracks. They can't find the right word that they want to use. They're having that word finding tip of the tongue, which can be really frustrating and sometimes embarrassing. And we've moved away from that professionally, from that term chemo brain, because it does imply that it's all the chemotherapy. Now, there's certainly good reason to think that the chemotherapy may be contributing, but what we know now is that there's quite likely an effect of having cancer itself, that cancer is an inflammatory process that may be affecting thinking skills. There are a range of other things like medication, sleep, emotional distress, substance use, changes to your sort of routine. Your level of stress does not go down when you get a cancer diagnosis. You have a lot more balls in the air and things to juggle. And so you're still dealing with the same family and managing work if you're still in that role and transitioning for some folks. And so there are a lot of things that really go into that. So we call it now cancer-related cognitive dysfunction or cancer-related cognitive impairment. Just to sort of broaden that term and let people know that there are more contributors and more avenues for intervention than just the chemotherapy and the treatment itself.
What are some of those avenues?
Sure, they really are dealing with the mood issues and getting that under control, enhancing coping skills, getting good sleep. Sometimes, cancer isn't a person's only diagnosis. They may have unrecognized sleep apnea that affects their thinking skills. They may be drinking a bit too much, and that may be in response, or it may just be something that they've been doing for a while, and we know that we can address that and help improve thinking. We can look at your medication list and keep an eye out for those medications that we know can be sedating or have cognitive side effects, and whenever possible, work with your medical team to help shift you to an agent that is going to be less cognitively compromising. So introducing exercise, establishing daily routines to help you sort of stay organized, and then using cognitive compensatory strategies, really focusing on your areas of cognitive strength and skills and using them in a targeted way to help overcome memory difficulties or difficulty with multitasking, for example.
Do people come to you, Rhonda and Sherri, with the same set of symptoms?
It's very interesting. As I was listening carefully, I was thinking there is such an overlap because although in my case, when people come to me, what I'm hearing is a pattern, what they start sharing with me is a new pattern of uncomfortable thinking. They usually start generating some type of limited thinking pattern, getting kind of stuck in, I should have done this, if I share my feelings, people may pity me. I'll never feel well again. They'll overgeneralize or really start to kind of have some negative thoughts. And I kind of share with individuals when they're with me, you've gone through this traumatic experience of getting the cancer diagnosis. And so, it's not the same thing as if if a rude, delivery person knocked on your door, caught you off guard, you go, oh my goodness, well, who is that? And then we realize that we're safe, automatically we realize that we're fine, and we relax our autonomous nervous system. And for individuals who get the cancer diagnosis, they ask a lot of questions that become unresolved to themselves. And so it swirls up in their brain, like kind of like a tornado with little bits and pieces of these questions. What if I only, and what do I do about my GI? So I get a lot of what I call in sessions stinking thinking, but they are managing a lot of complications, such as dealing with hair loss or having a GI complication, and even just stress. And stress, I do think, has some impact on cognitive function, because there's such a distraction piece to it. So I think that there are different levels that we would see: a lower level in my office and, a higher level in Tracy's.
And then what tools, Tracy listed some of the interventions that she began to think about with folks. And what are some of the interventions that in your office you walk through with people to address the same types of issues?
Well, one of the things that is always kind of like a repetitive theme is about knowledge is power, being able to kind of reclaim a sense of control, both mentally and physically. They're doing a lot of active things to get their body able to maintain its health during chemo treatment or during radiation, but there's a toll on mental health. And so what I would do is I help them they'll express themselves, and I can kind of share with them, is this the kind of thinking pattern, that you've had beforehand? And they're like, oh, they might say, well, yes, or they might say, no, back then I was able to. The other thing is I might reality check them and say, where's the evidence that this, terrible fear, of something happening may happen? I do find with having cancer, it's extremely understandable that dealing with a cancer diagnosis, nobody's giving absolute concrete information on any final outcomes. And that in and of itself presents a need for anybody who undergoes a cancer diagnosis to learn how it helps them so much to learn how to de-stress their mind, understand limited thinking patterns that might come up, and their pattern of thinking and what they want to return to in terms of self-help and calm.
Reverend Cooper, do patients come into your office and sort of say, I'm not myself, I'm not thinking through things clearly, my brain is fogged, or I feel like I have chemo brain and I can't quite function through my day? And what approach do you take when they bring these?
I do sometimes, but it tends to be in the context of who am I now that I have cancer? Like identity questions, questions of hope, questions of what is the future going to be? Where is my spirit in all of this? And sometimes when they, like one day, I often see people, especially who are admitted, where it's a new diagnosis. So it's like news, and they're kindly trying to get used to the whole thing. And they'll say, well, often people say, I divide my life into before cancer and after cancer. And I thought I knew who I was and what I believed before cancer. And now who am I and what do I believe? And that's when sometimes these issues, I do hear the word chemo brain a lot, or I can't, I'm not thinking straight, I don't feel like myself, and I have energy, and I used to be energetic. So it's like for me, when they're talking to me, they'll compare. Before cancer, this is how I was. Cancer, like before cancer, I felt like my faith was really strong, and I prayed all the time. And now I can't seem to pray, which I think sometimes is cognitive. Like it's hard to keep your attention. So I try to make them feel better about it, not worse. That it's part of what it is. But it's the meaning making, it's the hope, and just basic identity as who am I now? Who am I going to be? So yeah, it comes up a lot. Am I different? Will I ever be the same? They say.
And one of the things is it is a wonderful process to help them kind of reclaim the bits and parts of them that they've always loved about themselves, and to enhance that and become the best version. You were asking about strategies, and I just think it's so mindful to bring this up, and that is, I try to also educate individuals that you can actually measure your emotions. You know, for you to be able to people find it to be so intangible. They kind of say, I just feel like this. And so it's very empowering for individuals to learn how to measure their emotions. Could be positive or negative, but in three ways. One, by frequency. How often do I experience the emotion? Duration. How long does that emotion last? And intensity. You know, on a scale of 1 to 10, how intense is that emotion? And if they can onboard themselves to be like, I liked it better when I wasn't as, they can kind of become more accountable. You know, I also think it's important to teach them how to have decision-making models because of things like cancer-related cognitive dysfunction or chemo brain. I hope I said that right. You know, but to teach, you know, to help them understand a good balanced decision-making model. And then of course, I think some other obvious things is mind matters. We know that the mind body is connected. And so it's always wonderful to be able to share with them, you know, meditative practices and other types of restoring mind body balance practices for them.
I think along the continuum or the trajectory of cancer and treatment, at least where I interact with people, often are around issues of loss and gain, what they've lost and what they've gained. And again, it's a, you know, it's a continuum. Someone who's just been diagnosed usually is all about the loss, right? And as they go through treatment and begin to see themselves coming out on another side, they sometimes can reflect in their meaning making on what they've gained from it. And it's very poignant. The stories are very, I think I keep doing the job because I'm so touched by the stories that people tell and their quote spiritual growth, if you want to call it that. It's not all about being stuck. Some people are stuck. We're all stuck at some time, so I tend to normalize it. Maybe that's part of it. Yeah, those who are trying to find themselves often are trying to not find the positive. I don't mean it like that, or look on the bright side. It's more, what am I gaining from this? Not only what have I lost, but it's really both. There's no gain without loss, really. Very poignant, very poignant.
Yeah, I think there's you're absolutely right. There's such a tendency to focus on, we think about traumatic stress, but there is that flip side of traumatic growth, that when people are faced with a new challenge, something that they've never experienced before, it is an opportunity for them to learn about themselves, for their family to come together in some instances, and for bonds to be formed that are, or strengthened, that really had sort of not been there before. And people and families do come out changed. And in some ways, these are really positive changes for folks.
Well, even the people who tell us stories of like living in a subdivision or a neighborhood where they didn't know their neighbors well. But I've heard stories here where once it went around the neighborhood that the person was hospitalized or in treatment or not able to do, like the neighbors all come together. A woman told me they're mowing my yard, they're bringing meals to my children, they're taking them to school. This was last year when they were going to school, but she said, I never dreamed that people that I didn't really know well could care about me. I mean, how can that not change you? Change your heart? Yeah, really lovely.
So talking about changing things, and then somebody mentioned measuring things and measuring emotions. Is it, and this is sort of a scientific question, probably directed a little bit at Dr. Vannorsdall, can we measure changes in the brain through this process? And is it possible for someone to measure neurocognitive changes that they're experiencing? And can that information be used in some way?
Yeah, absolutely. So there's a couple ways that we think about tracking and measuring cognition. One is with what we call patient-reported questionnaires. So questionnaires that ask you about thinking skills and how you've been changing. And then the other is with actual pencil and paper tests where we sit you down and we assess different types of thinking, like your memory, your attention, your thinking speed, and see how you're doing compared to other people of a similar background. I always tell people you don't run as fast in your 40s as you did when you were 20. You don't think in the same ways as you age either. So we make sure that we're comparing you to people who are as similar to you in age, but also things like education. So we can really tell sort of what's your window of normal functioning, where are you sort of a standout, and where are you having difficulties? And we can track that over time. And when we do that in a group setting and for research studies, what we tend to find is that about a third of cancer patients will have cognitive difficulties before they start their systemic treatment, right? So there's something about the cancer itself that's even after you carve out all of the contribution from distress. So I think that's really sort of interesting. We think that there's sort of a cancer brain in addition to being a chemo brain, right? And so patients often will have slowing before they start their chemotherapy. When chemotherapy comes on board, what we tend to see is that memory takes a dip while patients are getting their chemotherapy. So sort of the pattern of thinking changes over time. And then generally as treatment ends and people start that march back towards the next phase, most patients will experience an improvement in their thinking skills, both on paper and pencil tests and in terms of their subjective sense of their thinking skills. So we can measure thinking that way and cognitive functioning. We can also look at your brain sort of in a scanner and see what happens as patients go through that same trajectory. And what we often see is that there are areas of the brain that shrink and then slowly come back. The white matter, which is sort of the highway for information that really sends information quickly across the brain, becomes thinner in some areas. And then over time, we believe that it sort of reverses course and people start to rebound a little bit. But we can see these physical changes in the brain that are paralleled by the paper and pencil tests and patient reports. And those will shift along the course of recovery as well.
Sherri mentioned mindfulness. And I sort of want to come back to what is mindfulness, but I'm going to start with parallel to that. Are there interventions like prayer and mindfulness and perhaps, we all hear about use it or lose it, so mental acuity activities that can similarly impact what you see on those tests?
Yeah, so mindfulness is a really interesting intervention that we're starting to get more and more actual hard data on. So meditation and those types of techniques. And I think they're really great for sort of the cancer-related cognitive difficulties because patients will often tell me that they have memory problems. They can't pull up new information from their memory. But what I often find on testing is that they're actually having attention problems. They're not paying attention. They're not in the moment. They're not taking it in the way they used to. And if you're not getting it in, there's nothing in there to pull out later. So the pulling out part is the memory. The attention is the getting it in. And so mindfulness and meditation practices can be really good at helping strengthen your brain's ability to pay attention, to be in the moment, and to be in the moment in sort of a non-judgmental sort of mindset that lets you take in information more readily.
And so Sherri, is mindfulness something that you work with your patients on, and what does that mean exactly?
Mindfulness is being able to have an honest perspective and viewpoint about your own personal well-being. If you can have an honest dialogue and think about what are my personal goals for myself and what I want to achieve from a mental health perspective. If I want to be a more productive worker at work, but I am having attentional issues, what can I do? If I am feeling too much distractional type stress because I'm trying to do so many things in between different appointments for my cancer treatment and still trying to now maybe homeschool my kids with their schooling, with all of these extra things. It's being able to look at what your personal ability for the output of what you're doing, how you're doing it, how well you want to do it, have some self-evaluation, personal kindness, and the ability to say, I am, and I love the term that Tracy was using. She was saying, you know, so through the traumatic experience of a cancer diagnosis, there's also traumatic growth. And I think that growth in not only the relationships, there's a growth in mindfulness that occurs with individuals because, as I'm sure in all of our different disciplines, we're asking people to be very attentive and accountable for what they think, what they feel, how they behave, and with their own best self-evaluation, they can be their personal best.
Reverend Cooper, you used a term at the beginning, unbelief, for those who label themselves as with belief and unbelief. And we're sort of talking about mindfulness. And I feel that all of these actually overlap quite a bit. When you use those terms, belief and unbelief, what distinction were you drawing, and what did you mean by those terms?
Well, some people that I meet, they will say, well, I'm a religious person, or I subscribe to this religion. And others will say, oh, I don't have any religion. I'm not a believer. You know, don't get that picture of me. I don't believe anything. And of course, we chaplains have a real bias about that everybody's spiritual. Whether you have a formal belief system or traditional, we believe everybody has the capacity for spirituality. If you search for meaning in your life, if you have people who are important to you, if you have values, if you have hopes, if you have dreams, we see that as the realm of the spirit. And so part of my challenge sometimes is, let's say, our nurses are great here, but they will send me a referral. They'll say, this person's not religious, but we think they need you. We want you to go see them. And so I'll introduce myself and they'll say, oh, I don't believe anything. I'm not religious. And so my goal is, you know, to meet them where they are and help them explore the ways they are very spiritual people, or people with a heart and spirit. So admittedly, sometimes people, this is not always true, but sometimes people are a little easier for me to connect with if we share similar, at least, religious beliefs. But that's not always true. Sometimes I connect with people who are just wonderful, spiritual, open-hearted, open-minded people that we find a connection. Does that kind of help? I mean, I think everybody's spiritual, whether they have a formal religious belief or not. Yeah. That's why chaplains can see anybody in the hospital and it's fine.
I think that's great. I mean, I sort of asked the question because I think increasingly a little bit sort of how mindfulness in some way is a form of prayer. It is in some ways a form of spirituality. And so when everybody was talking, I was sort of seeing this link in how we bring intention to things. Like you all sort of used similar but slightly different language to sort of talk about that idea. And so it's what brought me back to you sort of using those phrase of belief and unbelief as concepts, because I think sort of this spiritual was pulling out of what everybody was saying. So I think that's like a good start, a good phrase. Now, there's been a couple mentions of some very practical things like caregivers and worrying about caregivers and caring for caregivers and workplace and functioning in the workplace and how these affects, how these issues affect people's functioning in the workplace. And I think these are two big issues for folks. And so if we we'll start with one and then go to the other. So in terms of caregivers, I think probably all of you may interact in different, moments with different caregivers. And how do you how do you decide when to pull caregivers into the care of the patient? And when you're, I guess that's one question. And then sort of along with that a little bit too, how do you decide when the caregiver also needs caregiving and when they're experiencing many of these same actual issues, perhaps related to just the stress of the situation being a primary instigator as opposed to the chemo or the physiologic responses of the cancer diagnosis itself. So if we could talk about caregivers a little bit and how they're part of this process.
I can share with you, caregivers have shared with me a very wide scope of different types of supportive responses for their significant others. Sometimes their supportive responses or their supported what their loved one hears from them in terms of what the caregiver is giving them are things like, can I get you X, can I get you Y, can I get you Z, water, can I get you something else, can I help you? Silently, a lot of times, and the caregivers usually present in this fabulous, beautiful, supportive, loving front. Behind the scenes, without wanting to be a burden, the cancer patient doesn't want to feel like a burden to the caretaker. The caretaker doesn't want to feel like a burden to the cancer patient, but the caretaker many times will report, this is out of my wheelhouse. I'm usually the fixer. She comes to me and says, honey, I need the da-da-da. And he's like, okay, I'll take care of it for you. In this type of situation, it renders the caretaker a little bit feeling some sense of helplessness and needing to surrender that caretaking role, like being that person who can deliver the solution. He or she may have to surrender that to the healthcare professionals. And so sometimes for the caretakers, they sometimes hold a silent distress of their own because they don't want to have that be a burden for their loved ones. And it's not always very easy to ask that, but I will share with everyone the most helpful thing that everyone can do in supporting a cancer patient, in supporting a caretaker, or any loved one or healthcare professional involved with the care of a cancer patient. And that is honest and open communication. Non-judgment zone. We're going through something new together. How do we help each other through it?
Yeah. Well, like for let's say a patient who was the caregiver in his or her family and suddenly needs to be cared for, oh my gosh, talk about a loss of identity and not sure how to function within the family or within their choice of family. I think that gets really complicated because then those who must step up and be a caregiver, they're not used to that role either. And everybody's kind of trying to do their best. I know sometimes when I talk with either the caregiver or the person with cancer, it takes a lot of forgiveness and grace to kind of navigate those role changes many times, if that makes sense. There's no rule book on it. It's like everybody has to find their way, and it can be pretty painful finding that way. It has to be, but it's I think pretty challenging for most people.
Yeah, and I often find that, cancer affects families that maybe aren't doing so well. Not everyone is in a great spot in their marriage when this comes into their life, or things are going swimmingly with their children. There can be a lot going on. And so I think what you spoke about in terms of giving yourself grace and giving each other a bit of grace as you're navigating these new roles, that's something that I often find myself discussing with patients. And appreciating that the sort of personality quirks that might have been not your favorite. You know, some of those can sometimes be exacerbated in times of stress, right? If you are always, if you're the nice, tidy person and your partner is now forgetful, leaving things around the house, the refrigerator door is open, you know, those types of things, you know, trying to settle yourself before you react and remember that both of you are going through a difficult time and your partner may be having, you know, these sort of lapses or doing things that are more irritating because it's part of their coping or part of their sort of process. But it can be a real challenge.
I kind of always want to hear about, even if in the hospital, of course, not many caregivers are in the room, not many family members are in the room anymore. And so I like to, with patients, to hear the story of, in the South would say, who are your people? And whether it's your family or your best friends, whoever you choose as family. I like for them to tell the stories of their people to bring them into the room. Because getting that diagnosis or going through treatment, if you ever needed anybody, you need them then. Even for the practical parts of life, we hear stories of people struggling to figure out who will bring them for treatments or appointments, who's going to pick up the kids after school. I mean, there's some heartbreaking things that we hear, and then at the same time, some just amazing, gracious, full of grace things in terms of people. It's overused, but stepping up, becoming what they need to do. So in my assessment and meeting with people, I like to hear about who's in their life, who are their people, who's gonna walk with them, be with them, try their best with them. And in that context, we do sometimes talk about, we do often, identity and roles and forgiveness and grace and living with that which is less than perfect. Yeah, a caregiver is part of the deal.
What about work and all the thinking required with work and getting through work? And how do you help people decide what tools they need to get through work and when they need to actually say, you know what, maybe I need to not work? And what are some of the talking points, or what are some of the questions you pose to people to help them figure this issue out, working during a cancer diagnosis or cancer treatment?
Yeah, well, I often will see folks when they are sort of trying to ramp back into their former roles. So maybe they took some time off, maybe they didn't, but they're getting back to work, and they say, you know what, I look healthier. People expect me to be the me of before my diagnosis and treatment, and I'm on that path, but I'm not there, and there's some conflict there. They feel like they're not able to function as well as they had in the past, and that's distressing to them. And so one of the things that I'll often do is sort of talk with them about, what is your relationship like with your supervisor, right? Because there's a real range of of experiences, obviously. You know, what are your job responsibilities? Where are you finding that you're struggling and making errors? And then we talk about what we can do to sort of be really practical in terms of helping minimize those errors. Sometimes it's charting our fatigue and cognitive difficulties over the course of the day and figuring out, okay, I'm sort of at my best, you know, from around 11 to 12 in the late morning. That's when I'm going to do X. Or I know that I'm really bad. I've got poor visual skills right now, visual working memory skills. I'm trying to take something from one computer and put it on the other. You know, adding in extra time, writing out a checklist of procedures, even if it's procedures that you've done in your job for, you know, for years, having it written down, having it posted, and being able to sort of click through each task so that you don't have to try so hard to sort of get through the activities that you previously did. And sometimes we, you know, I'll write letters and indicate that somebody needs some modifications to their workplace in order to help them be successful in their revamping. Ideally, we sort of do that first. We set you up for success as you go back, part-time or on shorter days, because fatigue is often such a significant issue for patients as they're transitioning back into former roles. Setting things up so that they can, have little bits of success just to build up that self-confidence, because patients are often concerned that they're not going to be able to do the job that they used to do. And we do know that cancer survivors often will not put themselves up for promotions. They will not go for harder, work assignments due to fears of their cognitive functioning. And so we try to sort of, I think, nipping that in the bud and getting you set up successfully in the beginning can be really helpful and go a long way towards having a more enjoyable work career.
And many people simply struggle to work through treatment because they need their insurance, they need the income, they have people who depend on them. Again, it's like all of part of who they are that's put in such jeopardy by the diagnosis and treatment. Kind of like helping them, it's not a choice, or they don't feel like it's a choice, and it's helping them through that as well, or cope with when it's no longer possible. I've known patients who continue to work and resist, let's say, disability up until just weeks before they die, because it's so much in them that they're going to keep working or do what they can, so to speak, when they have some flexibility. Work defines them in a sense in terms of their identity. That's also a kind of a spiritual or a soul thing. Who am I if I'm not producing? Who am I if I'm not showing up? Who am I if I'm not dependable? Another identity.
Certainly, I think as a nation, we've recently had a very elegant example of that work as part of a spiritual practice example. It certainly brings up, each of you have sort of mentioned, we sort of touched on a little bit different avenues for accessing resources. One of the things that all of our patients always ask us, and we get a lot of questions about, is people go online, and for us, they do Dr. Google. So they use Dr. Google to find resources for the treatment issues, treatment-related issues, but there are definitely mind matter issues, which we're now going to call, I'm going to relabel heart matters and thinking matters, because I think certainly that's what's come out a lot tonight. But what are there resources that when patients ask you, people like to go on the internet, they like to do their own research. Are there reliable resources in each of your areas of expertise that you refer patients and their caregivers to for information that's a good source that you would say, please know about this?
For me personally, I tend not to do that just for reasons of liability. However, when I do give presentations and I am sharing something that is that comes from a resource, I always share that with individuals for them to get more information. However, it's so vast that while there is such a very broad range of generalized information out there, I think Dr. Google can work, but I'm not a big Dr. Google advocate because everyone is so individualized that I don't know how they may be, until they share with me, how they may be interpreting something that they may read, because it comes from their own perspective. When they read something that you or I may find to be very helpful, but they might find to read as very scary, So I'd rather a lot of their processing be more in the office, but I'm hoping the other professionals can share, some and help me and share some wonderful resources.
Well, I had a book that I loved by Shelley Kessler, who's a neuropsychologist. It was sort of a $12 book, less than 100 pages, that really went through sort of the biological mechanisms in a very readable way, and the interventions and where the research stands in terms of things we can do to improve our functioning. Unfortunately, I must have gone out of print because now it's like $100 on Amazon. So that is really disappointing. I'm on the hunt for new patient-friendly sources of information. I generally tell, our patients to make sure that they're going to sort of reputable websites, the American Cancer Association, these sorts of, they'll have cognition websites on, and pages devoted to thinking skills and coping. And so I really prefer that they stick to sort of mainstream. And patients often will come to me and say, well, what about ginkgo biloba? I read a study on the internet. Or what about CBD oil? Should I be doing cannabis? And so those, I think, I encourage people to let me know what their concerns are, what their interests are, and to always be forthcoming with their medical team about what they're taking, right? In terms of supplements, that they can't be hiding things. And they should always ask, because there are things like ginkgo that are really good for your memory if you are a rodent. But unfortunately, the big trials suggest that in humans, it just doesn't help. Probably going to hurt you, but your money is spent, better spent elsewhere. So I do think that sort of the Dr. Google gets people a lot of, should I be doing crosswords? Should I be doing Lumosity? Should I be doing, and, I encourage them to bring me their ideas and thoughts, and we can sort of talk through what we know we've got good evidence for, evidence against, and where things like CBD, it's all, hasn't been studied yet.
Oh, goodness. And so religion and spirituality, I mean, you can, I guess, Google yourself to death on that. So my advice for people is to identify their trusted other. And by that, I mean someone perhaps within their faith community or their closest circle of friends or people they trust, but the trusted other that will listen to them, let them talk without judgment, and just like go with them on the road. And sometimes that is someone within their faith community. Sometimes it's maybe it's their pastor or their rabbi or someone in their prayer group, or sometimes it's a person they'll go, oh, in my book club, there's somebody who's kind of seems spiritual and they always listen and they're always kind. And so for me, that's what I'm like, that's your resource. Your trusted other that you can call on the phone, that you can meet over coffee, that will just listen with their heart. That they're your best resource, even more than reading anything, or, even if it's like 10 minutes on the phone. Because, if you don't have much energy, you're not up for a whole hour conversation or meeting for a sandwich. You just need somebody. Some people tell me, in fact, it's kind of interesting, I'm not totally modern, but they have their trusted other texts, they text them back and forth. So when they need a word, when they need an encouragement or to know somebody's there, they text back and forth. I thought that was really interesting. People find their way. But that's my advice usually. Who's your trusted other? Who can you find if you don't have one? Sometimes it's a prayer partner. I mean,
Sherri, can I ask you a very, very practical question? We have a lot of patients come to us and say, I want to start in therapy. I want to find a therapist. I want to find somebody who can be a counselor. And I'm going to be honest, it is so hard to help people make that connection. And so what am I missing as somebody who wants to help people make these connections? There are often barriers to this, but what do you recommend to people who are listening, and then also to doctors who are listening? Sort of how do we help people make those connections? Or what does somebody do if they say, you know what, I really want to work with a therapist? Where do they find somebody?
So it's unfortunate that it's so difficult for individuals to find their therapist to work with. I do hear it kind of often. Yeah. The first place that I think everyone should start, if they don't already have like a personal resource or know somebody who specializes in something, is for individuals, if they can go onto their website for their insurance company, they can actually look up, a mental health specialist who is within their network, within their insurance, so that their insurance company can pay for it. So they want to find an in-network provider. For reasons of people not being able to get an appointment, it is either they are, choosing a practice that just doesn't have the openings. I do think that therapists are pretty much super saturated, not in the entire state, but there really are very, very many therapists. I will share with you, when I put my information on say Psychology Today, or if I'm on my insurance panel and I just need to update my credentials, there's always in this area of mental health, there's an area of special, an area of expertise. And I always wish that there was one for cancer, because there really isn't one therapist that, other than myself, I came across this in a very organic kind of way. But there aren't that many therapists who really just work with individuals who are dealing with the different effects of cancer in their lives. And I do wish that there were more therapists like that who would take that on board. But it seems to be a conundrum for people. I don't have an answer why people are unable to get them, but I do think that a great first step is for them to look through their insurance so that they know that they can have some financial coverage, and see who is available in their area through their insurance company.
And I've over the years sort of started putting together a list, because it is a real challenge. It's sort of less of a challenge now to match people up with telemedicine and telepsychotherapy, because we don't have those sort of distance restrictions, and it's easier than ever to see somebody from the comfort of your own home, which is really nice. But the insurance issues are still there. And so I have, the American Psychological Association has an online psychologist locator service. I'm sitting here looking at my cheat sheet. There are certain states that will provide lists of mental health providers that are sort of knowledgeable about medical conditions broadly. I'm trying to, the Association of Oncology Social Workers is another resource that I've sent patients to. But locally, I often will refer folks to our outpatient clinics here at the hospital or at Bayview, or to some of my colleagues who are here in our local area.
I always promise that we're not going to run over, and we're going to run over just a little bit tonight, but I hope everybody will find it worth it, and everybody will stick with me for just a few more minutes. Because I want to end on sort of one of my favorite mind matter, which is hope, and how everybody defines hope for patients when they see them. And so if each of you wouldn't mind ending us on how you define hope as a mind matter, and how, when people are feeling overwhelmed by disorganized thoughts or overwhelming diagnoses, or not being able to get back to themselves, how you frame hope for patients.
Hope is such a personalized word. I think it has many, many different meanings. I can certainly share with you what it means to me, but I recall going to one of the Johns Hopkins Gynecological Oncology seminars, and there were these breakout sessions, and I had attended one session that a chaplain was leading, and she was asking us, what are our definitions of hope? And I will share with you, it was vast. But in terms of how I would personalize hope, and what I try to infuse, in working with others, is for them to be able to develop or to tap into their own personal, expectations or desire for something to happen, for them to trust a process, that gives them good grounds for believing something good's going to happen. But I'm sure you'll get a lot of variations of how people would view hope.
Yeah, I think when I'm meeting with folks, I haven't thought about that, my own personal definition, but reflecting on it here in the moment, I tend to think that people are in my office because they do have some level of hope. They've made it this far because they're ready to hear what other options are available and what they can be doing. And so part of my role is to help open those doors, educate them, get them comfortable with some of the approaches that we can take to help them feel better moving forward. And so I think that sort of reaching out to providers is a hopeful act on the part of our patients. They're saying, you know, I trust that you guys know something that I don't, and that there's a way for me to start feeling or functioning better in some manner.
Reverend Cooper.
Sherri did a great job of saying pretty much everything I would say. Hope is so big, but it is expecting. There is a sense of expectation based in the past, based on who you are. I think oftentimes I get referrals or consults because people are trying to find out if they can have hope or what it would look like to them. And so my conversation is always totally around them. What do you think it is? And what do you hope will happen, either short-term, long-term? And my belief being, if they can talk about it and put it on the table in front of us, that there's a better chance that they can then apprehend it and take it and let it give them some energy to go forward, you know, to go to Tracy's office, to try to get back to work, to look for therapy. I mean, hope is energizing in so many ways. Even when you are very low in energy, hope can energize movement forward. But oh my goodness. Yeah, if you put it out there, what is hope to you? If you've got 20 people in the room, you've got pretty much 20 definitions. And that's why it's such a magnificent concept and so wonderful to work with people around hope. That's kind of one of my favorite things to do with people. But I do often get the referral because they're struggling to locate, I would say locate their hope and how it can take them forward. Yeah.
So we will end on that tonight. I thank everybody for joining us this evening. I think certainly what one walks away from the conversation tonight is that idea of hope. I think it sort of was a thread through everything that was discussed. I think for so many people, their identity is wrapped up in their heart matters and thinking matters and their mind matters. And so I think I appreciate greatly that the three of you were willing to spend time with us tonight talking about these issues and opening the door for conversation and hopefully for folks finding what they need to help them in their own individual ways. And next week for our final session, we are going to be talking about advocacy and awareness. So our topic next week is, we call it From Whispers to Shouts, advocacy for awareness, early detection and prevention. And so we'll have two of our gynecologic oncologists, Dr. Levinson and Dr. Beavis, with us. And so we look forward to seeing everybody next week. And again, thank you so much. You are all wonderful, wonderful. And we're glad you joined us.
Thank you.